خاف ارفع الصوت لأنه واطي.
صوتي أنا. The implant different advances in implant procedure.
دكتور عفاف
عفاف بس الصوت مش واضح.
Okay, I will try.
الصوت مش واضح عفاف.
الآن كيف الصوت واضح؟
أحسن هيك أحسن.
هيك ممتاز.
Okay, تمام. Okay, today we'll talk about the implant prosthetics, the new trends in advances in implant dentistry. Okay. As we know, the concept of osseointegration is not new. It dates back to the 1952, where Brennemark observed the bone tissue growth into bone marrows in titanium chambers that got incorporated in the bone tissue. But due to the lack of established protocol, the histological evidence remained inadequate until Schroeder finally demonstrated evidence of osseointegration and proved direct bone implant contact. And since then, lots of modifications in approaches have been introduced to improve this or to achieve higher percentage of direct bone implant contact and to enhance the quality of osseointegration. I will talk about the recent approaches to enhance the osseointegration of dental implants. Okay. It has been found that changing the topography of the implant can have significant impact on the quality of the osseointegration. It has been found also that the roughness of the surface up to a limit can enhance the osseointegration. So microtopography enhancements were proposed to aid in the attachment of osteogenic cells in bone deposition. By example, sandblasting and acid etching. Similarly, nanotopography enhancements act on the protein level by increasing the adhesion of osteogenic cells and promoting osseointegration. An example of this category is laser ablation, which generates nanoscale microchannels that triggers the connective tissue and bone attachments and inhibit the epithelial growth. So it prevents the down growth or the apical growth of the junctional epithelium. Another example of these approaches is the surface wettability improvements. The more hydrophilic the surface, the better the cellular attachments, because it prevents the denaturation of the proteins. Okay. Another one is the photofunctionalization using the UV radiation. As we can see in the figure on the left, the application of UV light on the surface of the implant can increase the can make the surface more hydrophilic. It can also alter the titanium dioxide surface layer and improve protein absorption, cellular attachment, and restore bioactivity that gets diminished after age. Okay. Another approach is by using surface coatings. These can be multiple substances like growth factors, platelet-derived growth factors, fibroblast growth factors, and peptides. These are the natural layers in the process of osseointegration, so therefore they can hasten the process. Okay. Some studies reported that the addition or coating the surface with drugs like bisphosphonate can improve bone density and was associated with higher ISQ values. Local drug delivery of drugs like melatonin can also increase the bone density. Okay, now we are done with the surface treatments. Let's talk about the recent advances in the material that can be used to fabricate dental implants. The old materials or the currently materials that we are using are titanium and titanium alloys. These are have long been used as the materials of choice for dental implants. There are also ceramic-based materials like zirconia taffend alumina, and alumina taffend zirconia. These gain popularity because they achieve better aesthetic properties than titanium implants. And we have the tantalum implants. The porous tantalum, or also called as trabecular metal, as you can see in the figure on the left, because of the honeycomb appearance of the surface. It's used, it has been used successfully in orthopedics surgeries, but for dental use, the evidence or the studies are still lacking. Okay, and we have the polyether ether ketone. Distributes the stress evenly over the implant, but the problem with the PEEK is that it does not produce osseointegration. Only chemical interlockings can be achieved between the PEEK and the bone. So surface modifications are needed with hydroxyapatite, titanium oxide, and magnesium phosphate. Okay. Now we are done with the physical or mechanical parts of the implant. Let's talk about the custom abutments for optimal fit and aesthetics. So to make sure that we are all on the same page, let's talk about the different types of implant abutments. They can be categorized according to the type of implant abutment connection. We have the external connection, internal connection, abutment connection with interrotational features and without interrotational features. We have also abutments according to the type of the material. You have titanium, stainless steel, cast gold, ceramics, and PEEK. We also have abutments categorized according to the retention of the prosthesis. We have cement retained, screw retained, and abutment for attachment. And according to the fabrication method, we have prefabricated stock abutments. We have custom made, which can be categorized into customizing the prefabricated abutments, or fully customized, which can be CAD/CAM or copy milling. And we have temporary and permanent abutments, which can be the temporary abutments can be for impression abutments, healing abutments, and provisional abutments. Okay, now we will talk about the custom abutments. So first, what's the rationale behind the customization of the abutments? When we have customized abutments, we have better control on the abutment contour, emergence profile, abutments margin, and lower mechanical complications. They are also reported to have better soft tissue stability when compared to stock abutments. Okay. So the very first customized abutments with UCLA design. In this design, we have the metal base, and we have a chimney over it, plastic chimney over it. So the shape as it is, the prefabricated shape is useless. It needs to be customized in order to be used. So the clinician can do conventional wax up over the plastic sleeves or chimney, and then it's casted like the conventional way to fabricate customized abutments. These are very old now and are replaced with CAD/CAM abutments. The CAD/CAM abutments, the first CAD/CAM abutment was the Atlantis from Dent Supply Sirona in the 1999. They have a software that contained abutment design templates, so we don't need wax patterns anymore. And to improve the aesthetic, because the titanium abutments are silver, have silver metallic color, it can show through the gingiva when the patient has thin gingival biotype. So they are made with coated with titanium nitride to have this gold hue abutments. Okay. So these abutments can be made of titanium or zirconium oxides. They can be completely milled out of these materials, including the implant abutment connection. Okay, and as we said, to overcome the silver metallic color of the original or conventional titanium abutments, now we have the gold titanium abutments. They are alternative to the old ceramic or the zirconia abutments. Okay, and they can be used in situations for patients with in biotype or when the aesthetic is of a concern. Okay, or we can have the zirconia abutments, but the zirconia abutments is associated with several drawbacks and shortcomings. It has been proven that the zirconia abutments have significantly worse fit or less fit than the titanium abutments because the metals can be accurately milled in contrast to zirconia abutments that are made of zirconia. The zirconia cannot be machined as accurately as the metals. Okay, the mean gap size in zirconia abutments was reported to be 3 to 7 times larger than the titanium abutments. And the other big problem is the high rate of fracture because these materials are brittle. The zirconia is brittle. Another issue associated with zirconia abutments is as we know, the zirconia has a very high flexural strength. And this difference between the hardness or the flexural strength of zirconia and titanium can cause wear and damage of the internal components of the implant fixture. Therefore, the one-piece zirconia abutments are not commonly used nowadays, and the concept of hybrid abutments was proposed. Okay. Now, the hybrid abutments, we have the titanium insert, and then we have the ceramic. It could be zirconia or lithium disilicate mesostructure over it. Okay, so it consists of titanium insert with connected ceramic mesostructure. They have many advantages. They can have improved aesthetics, optimal biological response, and superior mechanical properties with no adverse effect on the implant abutment interface because now we don't have difference in the mechanical properties between the connection between the implant and the abutment. Okay, the titanium insert is usually prefabricated by the implant manufacturers. And its accuracy is as high as the titanium abutments, and the ceramic mesostructure is customized using CAD/CAM technology based on the aesthetic and functional needs of the patient. Materials that can be used to fabricate hybrid abutments are zirconia and precrystallized lithium disilicate. As you can see here, we have perforation in the CAD/CAM block to represent the connection between the mesostructure and the insert. So they can be used either as a separate crown, separate abutment and crown to be used for cement retained restorations, or can be used as a one-piece hybrid abutment crown with the abutment and crown fabricated as one piece, as you can see here in the picture. It's usually made for screw retained restorations. Okay, other materials include hybrid ceramics blocks, which have integrated connection, as we said, compatible with the titanium base, the perforations here, and we have the polymethyl acrylate to fabricate provisionals for implant restorations. Okay, now we are done with the mechanical part or the physical parts of the implant. Let's talk about the virtual implant planning and the guided implant surgery techniques. Okay, So in order to have a guided implant surgery, we need a surgical guide, right? So the surgical guides can be fabricated using two techniques, or we have two broad categories for the guided implant surgery. We have the static approach, and we have the dynamic guided approach. For the static approach, we use the surgical templates with a fixed sleeves or holes in the template, which will guide us to the final position of the implant. And the implant position cannot be altered during the surgery. It's fixed and it's oriented by the sleeves in the template. While for the dynamic approach, we can use virtual implant positioning from the computerized tomographic images. It provides real-time, real effect positioning of the implant intraoperatively. It's like a GPS during the procedure. It orients the clinician to the exact position of the implant. We will talk about it in the coming few slides. Okay, so for the methods of fabrication, surgical guides, we can make it through the model-based techniques. They can be fabricated manually using the CAD/CAM or milling or printing. The disadvantage of this technique is that because it's fabricated manually, we have many manual steps, so there is increased risk of having errors. Or we can make it by stereolithographic or rapid prototyping technology. This technique includes fully digital planning and printing of the guides, and it's more accurate with the least manual steps. Another important part of the guide is the guide supporting surfaces. The supporting surfaces for the guide can be tooth supported, where the remaining teeth supporting the guide, at least two teeth are needed, or the mucosa supported for edentulous patients, or it can be bone supported. And this type of support has the higher chance of inaccuracy. It's the least accurate. So we can place many implants or pins to fix it, and this type is called special supported surgical guides, as we can see here in the pictures. Okay, we talked about the two types, which are the static and the dynamic approaches. The static approach can be divided to two categories: the fully guided and the partially guided. For the partially guided static technique, the only osteotomy or the pilot drill is being done using the surgical template. We use the surgical guide to drill with the pilot drill, and then we remove the surgical guide, and then we place the implant freehand. And this is called partially guided implant surgery. For the fully guided, the surgical guide is used to place or to prepare the implant position or implant site and to place the implant. So implant placement is done using the surgical guides. Okay, according to the international, to the consensus, the ITI consensus, the fully guided protocol performed more accurately compared with the partially guided systems. Okay, and then we have the dynamic navigation system approach. In this system, we said it's like a GPS. It's a real time tracking of the motions of the handpiece during the preparation of the implant site and during the placement of the implant. So the system composed of, as you see in the picture on the left, we have this unit with a head position here over the head of the patient. We have the emitting light unit with two cameras attached to it, and we have the computer, and we have the two attachments, one attached to the patient's mouth to the surgical guide, and one to the handpiece. These attachments has buttons over them, So when they are placed on the handpiece and the patient's mouth, when the light is transmitted over them, the camera can read these patterns and determine exactly where the handpiece is and where the technician is drilling in relation to the intended implant position. Because we have on the software, on the computer, we have made the virtual implant planning, and we have the final position of the implant. So when the technician is moving the handpiece, they can tell where they are from the intended implant position. This system is the X-Guide Dynamic 3D Navigation System from Nobel Biocare. Okay, here is a video for more illustration. This table is for calibration of the handpiece. We can see how the clinician can see exactly the intended position of the implant and the where they are drilling. And here is the final implants. Now, when we compare the static and the dynamic approaches, the static is used more commonly in peri-edentulous patients, where the navigation approach is very useful for patients with limited mouth opening, because we do not rely on visualization of the site of the implant placement in the patient's mouth. We view the field through the screen, so we don't need the patient to open wide. Okay. The advantages is that it allows, as we said, real-time tracking of the osteotomy drilling and implant placement using shorter surgical instrument in shorter time. The disadvantages is that it's very costly for investment when compared to static systems. It still have these systems still have various difficulties to practice in a daily scenarios, and a team approach is needed to learn to work together and for easy use. I mean, it's not easy, it's still complicated. Okay, now let's talk about the digital workflow for guided implant surgery. In order to have digitally guided implant surgery, first we need to have the data collection through CBCT and oral scanners, and then we manipulate the data and process the data through virtual implant planning softwares, and then we do the virtual prosthetic setup, virtual implant placement, and surgical guides design, and then we fabricate the surgical guide and the prosthesis. Okay, so that data collection can be done, or we need two things. We need the CBCT and we need the surface optical scanning. For the CBCT, it can be obtained through different methods. For dentate patients, the CBCT is obtained with or without radiographic guide, because we use the teeth surfaces as references, so we don't need the radiographic guide for dentate patients. For edentulous patients, we have two options. The first option, we make a copy in a radio-opaque resin of the patient's prosthesis, and then the patient is asked to take one scan with the prosthesis in the mouth. And the other option is the dual or double scan procedure. The dual scan procedure or double scan procedure, it's the primary approach for the edentulous patients. First, we make sure the prosthesis is radiolucent. It must be radiolucent, and it must be well fitted. And then we make the fiducial markers or radiographic markers, can be getaberka or any radiopaque material. We place it attached to the denture, and then we ask the patient to wear the denture and take the first scan. It must be taken with the patient in occlusion, okay? And then the second scan, CBCT, for the is performed for the denture, as you can see here. The internal surface of the prosthesis will represent the soft tissue of the patient. Okay, now we have the picture on the left. We have the prosthesis. Here is the data of the prosthesis, and here we have. Wait a minute, let's. And here we have the patient wearing the prosthesis. Okay, and then we can superimpose or align the two scans using the fiducial markers that we made earlier on the dentures. And here we have the prosthesis aligned to the patient's cranial base, and it's positioned exactly like it was positioned in the patient's mouth. Okay, and then the data can be imported in programs made for virtual implant planning like Implant. You know, the data is ready for virtual implant planning. Okay, the second thing that we need to obtain for the TAPE patients is the oral scan. The scan can be created via direct or indirect methods, and then it's saved in STL format, and then the data from the that we obtain from the CBCT and from the STL files are imported into the digital implant planning softwares. As we said, Implant is one example of these softwares, and then we are ready to make the virtual model. Okay, now we have on the left is the data obtained from the CBCT, and on the right, the one obtained from the oral scanner. We use the teeth, as we said, as a reference to superimpose these two the data from the patient. Okay, so we don't need radiographic guide or fiducial markers. Okay, and then we merge the CBCT and surface data sets. As we can see here in the purple or the pink one is where we merged the two data sets. Now it's ready for virtual implant planning. Okay, now we have accurate virtual patient model, and we are ready to make our virtual planning. We can choose now the implant type and implant size according to the available bone. We can choose the type of the prosthesis, the abutments, and we can design the surgical guide. After we decide the type of the support, and as we said, we need at least 2 teeth to support the guide. And then we can make the virtual wax-up, and this wax-up can be used to fabricate custom-made provisional restorations for immediate loading or definitive prosthesis. Okay, now we have the design of the surgical guide in the software. It's ready to be manufactured. It can be manufactured through additive, rapid prototyping, or subtractive milling techniques. Okay, sorry, it's step number 5. It's the surgical execution. We have the surgical guide, we place it and fix it in the patient's mouth, and then we place the implants. Irrigation is very important because using the surgical guides can cause overheating to the bone, produce more heat than the freehand techniques. Okay. Now these are examples of commercially available virtual planning systems. Semblance, we talked about it, and Nobel clinician from Nobel Biocare and Implant Studio from 3Shape. And all these systems are open systems. We can choose implant systems from any other company. The last thing I will talk about is a digital smile design. It's a protocol for digital smile design, computer-aided surgery, and all in for rehabilitations.
Okay.